Usually when we talk about a medical diagnosis, there's this expectation of um, pure mechanical precision.
Right, like an absolute certainty.
Yes, like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is. That's the problem.
It is a comforting way to view medicine. I mean, we naturally gravitate toward things that are visible, localized, and, perfectly categorized, broken or not broken.
But step into the world of metabolic disease and, well, that x-ray machine is totally useless. We're looking at a diagnostic landscape that is entirely systemic and, frankly, largely invisible.
Completely invisible to the naked eye, yeah.
So today we're taking a deep dive into the clinical manual Diabetes Secrets. And our mission for you, the medical learner or young professional listening, is to understand exactly how the machinery of the human body breaks down in diabetes mellitus.
Because it really is a whole body breakdown.
Right. We aren't just going to list symptoms today. We're finding out the why behind the pathophysiology, the underlying mechanisms of the acute and chronic complications, and the exact mathematical precision required to fix it with modern pharmacology.
Which is such a vital perspective to take. I mean, diabetes is rarely just a disease of high blood sugar, even though that's kind of the dominant public misconception.
Yeah, totally.
It's actually a complex multi-system syndrome. To manage it, or even to comprehend what a patient goes through daily, you got to understand the mechanics starting from the cellular level, moving all the way up to the cognitive load of just, survival.
And to figure out how to treat the disease, we first have to understand the origin of the breakdown. The manual clearly separates the foundation into two distinct pathologies. Let's look at type 1 diabetes first. T1D. This is basically an autoimmune strike, right?
It is, yeah. In type 1, the body's own immune system actively hunts down and destroys the pancreatic beta cells.
And those are the ones making insulin.
Exactly. Those are the specific cells responsible for synthesizing and secreting insulin. So the result is an absolute deficiency. The factory isn't just sluggish, it has literally been burned to the ground.
But how do you actually prove that clinically? I mean, you can't just look at someone's pancreas in the clinic.
Well, you look for the biological debris. The diagnostic hallmark here is a low or completely undetectable serum C-peptide.
Wait, pause there because that's an interesting detail. Why are we looking at C-peptide instead of just, measuring their insulin levels directly?
Because of how insulin is manufactured. The pancreas actually originally produces a larger precursor molecule called proinsulin.
Okay.
To make active insulin, an enzyme snips off a connecting piece, and that piece is the C-peptide. So, for every single molecule of endogenous insulin your body makes, it produces exactly one molecule of C-peptide.
Oh, I see. It's a 1-to-1 ratio.
Right. And since C-peptide stays in the bloodstream much longer than insulin, it acts as a highly reliable tracking footprint. If C-peptide is undetectable, the internal factory is shut down. And alongside that, you screen for the weapons the immune system used, specific autoantibodies like GAC, IA2, and zinc transporter 8.
Okay, let's unpack this. So type 1 is this aggressive, targeted internal strike. But type 2 diabetes, T2D, feels like a totally different beast.
Oh, absolutely.
We used to think of it as just insulin resistance in the muscles and maybe a tired pancreas. But this manual introduces a concept by Dr. Ralph DeFronzo called the ominous octet, which honestly sounds like a villain group from a comic book.
Yeah, from a metabolic standpoint, that's actually a pretty fair characterization. T2D is highly polygenic, heavily influenced by acquired factors like obesity and chronic stress. DeFronzo proved that the pathology is far wider than just the muscle, liver, and pancreas.
Right, the classic triad.
Right. He identified 8 distinct physiological defects operating simultaneously.
8 different departments actively sabotaging the body. Wow. Walk us through a few of the surprising ones, because everyone already knows about the pancreas and the liver. What else is going rogue here?
Well, let's look at the brain. The brain. In a healthy system, insulin crosses the blood-brain barrier and acts on the hypothalamus to signal satiety. It literally tells your brain, we have enough energy, stop eating.
Okay.
But in type 2 diabetes, the brain itself develops severe insulin resistance. It never receives the signal, which drives hyperphagia, basically an insatiable appetite, which further fuels the metabolic fire.
Wait, really? The brain itself stops listening to the fullness cue. And so the weight gain isn't just a lack of willpower, the biological signaling mechanism is physically broken.
Precisely. It's structural. And then you have the gastrointestinal tract, which suffers from a deficiency in incretin hormones.
Incretins, right.
Normally, when you eat, your gut releases incretins that prime the pancreas to release insulin before the sugar even hits your bloodstream.
Like an early warning system.
Exactly. But in T2D, that early warning system is totally muted. You also have fat cells aggressively breaking down stored triglycerides into free fatty acids, a process called lipolysis, which actively poisons the remaining beta cells. And if that wasn't enough, the kidneys inappropriately upregulate specific transporters, meaning they reabsorb glucose back into the blood instead of filtering it out into the urine like they're supposed to.
That is terrifying.
Huh.
It's a massive systemic management failure. The brain wants more food, the gut won't sound the alarm, the fat cells are releasing toxins, and the kidneys are basically hoarding the sugar.
Right.
And the manual notes that many of these defects are already active during prediabetes. Without serious lifestyle intervention, about 11% of prediabetic patients progress to overt T2D every single year.
It is a ticking clock, and because the disease involves a multi-system failure across those 8 departments, diagnosing and managing it requires far more than just a routine blood test.
Which brings up a huge logistical problem. If the pathology is this widespread, how do you evaluate a breakdown like this in a standard, 15-minute clinic visit?
You really have to expand your view. A comprehensive evaluation has to go beyond the physical body. The clinical manual emphasizes that evaluating the patient's psychosocial landscape is just as mandatory as checking their A1C.
Okay, so what does that look like in practice?
You have to utilize standardized screening tools like the PHQ-9 for depression and the DDS, the Diabetes Distress Scale.
Why a specific scale for diabetes distress, though?
Yeah.
Is it really that different from generalized anxiety?
Oh, very different. The DDS specifically measures regimen-related emotional burden. Think about it. We are asking patients to act as their own artificial pancreas 24 hours a day, 7 days a week.
Yeah.
They're making mathematical calculations every time they eat, exercise, or even just get stressed. The cognitive load is staggering, and furthermore, providers must evaluate social determinants of health.
Right, the real-world factors.
Yeah. A patient cannot prioritize advanced carbohydrate counting if they are facing imminent housing instability or, severe food insecurity.
I can totally imagine how ignoring those realities leads straight to what the book calls therapeutic inertia, where a patient's numbers aren't improving, and the clinical team just kind of shrugs, refills the exact same prescription, and says, let's check again in 3 months.
Yeah, and therapeutic inertia is incredibly dangerous. To combat it, the text recommends utilizing point-of-care A1C testing, getting the blood glucose average in the room right during the visit.
So you don't lose that momentum.
Exactly. So treatment decisions are made immediately rather than waiting days for lab results.
But I want to push back on the provider-patient interaction here. If you suspect a patient is non-adherent, let's say they're rationing their insulin because of cost, or they just have pill fatigue, how do you actually uncover that without sounding accusatory? Because if a doctor wearing a white coat asks, are you taking your meds? Human nature dictates the patient will just say yes to avoid a lecture.
That is such a crucial point. You have to deliberately neutralize the guilt in the room. The clinical strategy is to use normalizing, open-ended questions. Instead of asking if they take their medication, a skilled clinician asks, how many times did you miss a dose last week?
Oh, that's clever. It frames missed doses as a normal, expected part of the human experience.
Yes, it assumes the reality of the struggle, which instantly builds trust.
It gives them permission to be honest.
Which is the only way you get clinically useful information.
But even with the most compassionate outpatient management, sometimes the system just snaps, right? Adherence fails, maybe an infection spikes their cortisol, and the patient crashes into the emergency room.
Yeah, the extremes. When extreme metabolic decompensation occurs, it primarily manifests as one of 2 major crises: diabetic ketoacidosis, or DKA, and hyperglycemic hyperosmolar syndrome, or HHS.
Okay, here's where it gets really interesting for the medical learner. Let's put ourselves in the ER. To an untrained eye, these two can look remarkably similar. Both patients roll in dangerously hyperglycemic, profoundly dehydrated, and lethargic. What is the actual physiological differentiator?
The differentiator is entirely based on the body's insulin status and how the liver responds to it. Let's take DKA first. DKA is characterized by significant hyperglycemia, ketonemia, hypovolemia, and a severe anion gap metabolic acidosis.
And that's mostly type 1, right?
Predominantly, yes, though not exclusively seen in type 1. Now, HHS presents with extreme hyperglycemia, hyperosmolality, and profound dehydration, but without significant ketones or acidosis. HHS is mostly seen in elderly type 2 patients.
Let's break down the mechanism there. Why does one patient produce ketones and turn their blood acidic while the other doesn't?
It comes down to absolute versus relative insulin deficiency. In DKA, there is zero insulin, none.
The factory is burned down.
Right. So the cells are surrounded by glucose, but without insulin to unlock the cellular doors, the body believes it is literally starving to death. In a panic, the liver aggressively metabolizes fat into alternative energy sources called ketones.
And ketones are highly acidic.
Highly acidic. As they flood the bloodstream, they consume the blood's natural buffers, like bicarbonate. When we draw their labs, there is a sudden glaring gap between the positively charged ions, like sodium, and the negatively charged ones.
The anion gap.
That is the anion gap. It indicates the blood pH is dropping to life-threatening levels.
So what happens in HHS then?
In HHS, the patient usually has type 2 diabetes. They still have a relative presence of endogenous insulin. That tiny trickle of insulin is completely inadequate to control blood sugar, which is why the glucose levels rise to staggering heights, sometimes over 800 or 1,000 milligrams per deciliter.
Wow, 1,000.
Yeah. But that tiny trickle is enough to signal the liver to halt lipolysis. It prevents the massive fat breakdown, so ketones and acidosis never actually develop.
The trickle of insulin acts like a dam against the acid. But what about the hyperosmolality you mentioned? If the sugar's at 800, what is that doing to the blood itself?
It essentially turns the blood into syrup. It becomes highly concentrated, or hyperosmolar. Through basic osmosis, this syrupy blood forcefully pulls water out of the surrounding tissues, including the neurons in the brain.
Oh, pulling water from the brain.
Yes, leading to profound intracellular dehydration and often a comatose state.
That paints a vivid, terrifying picture. But let's say our patient survives the ER. They manage to stabilize. They are still fighting a quiet, chronic war because even slightly elevated glucose over years and decades acts like a slow-moving acid on the body's infrastructure.
The microvascular and macrovascular complications, yeah. Historically, we thought of diabetic kidney disease nephropathy merely in terms of tracking protein in the urine, but the structural damage is profound.
What's actually happening at the cellular level?
The high glucose causes proteins in the blood to become coated in sugar molecules, forming advanced glycation end products, or AGs.
AGGs. So the sugar physically gums up the machinery.
It stiffens the filtration barrier. You see a thickening of the glomerular basement membrane, mesangial expansion, and the literal death and detachment of podocytes.
Podocytes.
Those are the specialized cells that wrap around the kidney's capillaries to filter waste. Once the podocytes are lost, they don't grow back.
Man, and the damage doesn't stop at the kidneys. It absolutely shreds the nervous system, too.
Oh, diabetic neuropathy compromises multiple nerve pathways due to a mechanism involving the sorbitol pathway. The excess glucose saturates the nerves and is converted into a sugar alcohol called sorbitol.
Okay, so sugar turning into alcohol inside the nerve.
Right, and sorbitol cannot easily cross cell membranes, so it gets trapped inside the nerve cells. It draws in water, swelling the cell and causing severe oxidative stress.
That explains why the nerves actually die.
It destroys afferent sensory nerves, leading to a loss of protective sensation in the feet. It degrades efferent motor nerves, causing structural foot deformities. And it attacks the autonomic nervous system, leading to dysautonomia.
Meaning the background processes fail.
Exactly. The automatic background processes of the body start failing. Patients can develop gastroparesis, where the stomach basically paralyzes, or severe orthostatic hypotension, where their blood pressure drops dangerously just from standing up.
Treating this disease is literally about protecting the plumbing and the wiring of the entire human body. And the plumbing takes the most lethal hit when we talk about macrovascular complications, right? Atherosclerotic cardiovascular disease, or ASCVD, and heart failure are still the leading causes of death here.
Because the chronic inflammation aggressively accelerates plaque formation in the arteries.
So knowing this massive scale of damage, how do we intervene scientifically? We can't just throw insulin at everyone. We must deploy targeted non-insulin therapies based on the patient's specific risks.
Exactly. We use pharmacology that targets the specific mechanisms we've discussed. Let's look at the classic oral medications first, like metformin.
Right, the gold standard. But how does it actually lower blood sugar? I mean, does it just act like synthetic insulin?
No, it works primarily on the liver. Metformin activates an enzyme called AMP-activated protein kinase, or AMPK.
Okay.
AMPK is essentially the cell's energy sensor. By activating it, metformin tricks the liver into thinking the body is in a low-energy state, which forcefully inhibits the liver's ability to pump out extra glucose.
Fascinating.
Then you have sulfonylureas, like glipizide. These work by physically binding to and closing KATP channels on the surface of the beta cells.
Potassium channels.
Right. By closing those potassium channels, it alters the electrical charge of the cell, forcefully squeezing the pancreas to secrete more insulin.
Okay, so metformin is a brake pedal for the liver, and sulfonylureas are physically squeezing the pancreas. But those are the older guard. The newer classes of medications are fascinating because they seem to actively target the other rogue departments in that ominous octet we talked about.
What's fascinating here is how modern guidelines have completely shifted. Let's talk about SGLT2 inhibitors, the drugs ending in gliflozin.
Yeah, how do those work?
SGLT2 inhibitors fundamentally change how the kidney handles sugar. Remember how the diabetic kidney inappropriately reabsorbs glucose?
Right, hoarding it.
Well, these drugs block the sodium-glucose cotransporter 2 in the proximal nephron. So instead of reabsorbing the sugar, the kidney dumps it directly into the urine.
Hold on, I have to challenge that. If we are forcing the kidneys to dump massive amounts of excess sugar into the urinary tract, aren't we just creating an energy-rich buffet for bacteria and yeast?
We are. That is the exact physiological trade-off. Genitourinary infections are a major, well-documented risk of SGLT2 inhibitors. And there are risks of volume depletion and euglycemic DKA, too.
So why use them?
Because the benefits often drastically outweigh the risks. By dumping the sugar, you are lowering the vascular volume and reducing the workload on the heart. SGLT2 inhibitors provide profound, specific benefits for reducing ASCVD risk and preventing hospitalizations for heart failure.
Oh, wow, so it's actual organ protection.
Yes. Modern guidelines now prioritize them specifically for that heart and kidney protection, not just for glucose lowering.
And then we have the GLP-1 receptor agonists, the injectable medications that are basically making headlines everywhere for weight loss right now. How are they working within this system?
Well, GLP-1s are synthetic versions of those gut incretin hormones we discussed earlier.
The early warning system.
Right. And they address multiple defects in the octet simultaneously. They enhance glucose-dependent insulin secretion, meaning they only stimulate insulin when sugar is actively present, drastically lowering the risk of hypoglycemia.
That's a huge safety benefit.
It is. They also suppress excessive glucagon from the liver. They slow down gastric emptying, so sugar enters the blood slower, and crucially, they cross the blood-brain barrier to act on the hypothalamus.
To fix that broken signaling.
Exactly, restoring that lost feeling of satiety. They're preferred before insulin and T2D precisely because of those weight loss benefits and the lower hypoglycemia risk.
So they are fixing the gut defect, the liver defect, and the brain defect all at once. It's brilliant. But eventually, due to the progressive nature of beta cell failure in type 2, and immediately for everyone with type 1, the pills and non-insulin injectables aren't enough.
No. Eventually you have to replace the hormone directly.
And this is where the manual gets into the sheer mathematical precision required to keep a human being alive.
Insulin therapy requires absolute exactness. And actually, before the math, the physical administration mechanics matter. Insulin is a biological protein. Unopened vials must be kept cold in the fridge, but the currently used vial should be at room temperature to prevent painful tissue damage upon injection.
Okay, that makes sense.
More importantly, suspension-based insulins, like NPH, separate as they sit. They must be physically resuspended by rolling the vial gently at least 20 times before drawing a dose.
Wait, 20 times? What happens if a patient doesn't roll it?
If you draw from a separated vial, you might draw pure concentrated active insulin one day, resulting in a severe hypoglycemic crash, and mostly inactive fluid the next day, resulting in hyperglycemia. The absorption becomes highly erratic.
Incredible. Okay, let's talk about the math for dosing mealtime insulin. The manual breaks down two crucial formulas: the carbohydrate to insulin ratio, or CI ratio, and the correction factor, or CF.
Right. The CI ratio tells you how many grams of carbohydrates 1 unit of rapid-acting insulin will cover. To find a starting point, clinicians divide the constant 500 by the patient's total daily dose of insulin.
Okay, the 500 rule.
Then the correction factor determines how many points 1 unit of insulin will drop an elevated blood glucose level. That is calculated by dividing 1650 by the total daily dose.
Okay, pause. Because if I'm just listening to this while driving or making dinner, hearing divide 1650 by the total daily dose sounds like an SAT word problem.
Yeah.
Let's ground this in reality. Imagine a patient is staring at a plate of pasta. It has 42 grams of carbohydrates. Their pre-meal blood sugar is a bit high. Let's say it's 180, but their target is 100. And their calculations show a carb ratio of 10-1 and a correction factor of 40-1. Walk us through the cognitive load of what they have to do right before they eat.
They have to perform a two-part calculation. First, the pasta. 42 grams of carbohydrates divided by the ratio of 10 means they need 4.2 units of insulin just to process the food.
Okay, and we round that down to 4 units.
Right. But they still have to fix the high blood sugar they currently have.
Exactly.
They're at 180 wanting to be at 100. That is an 80-point gap. Their correction factor is 40. So they divide the 80-point gap by 40, which equals 2 additional units.
So 4 units for the pasta, 2 for the correction.
Yep. They add the 4 units for the pasta to the 2 units for the high blood sugar correction, draw up exactly 6 units, and inject.
Every single time they eat. And the variables are never static, right? Stress, a bad night of sleep, a brisk walk. All of it alters how that insulin will behave.
If we connect this to the bigger picture, this is exactly why continuous glucose monitors, or CGMs, have revolutionized care. They act like artificial pancreatic islet cells. By measuring interstitial glucose every few minutes, they provide real-time data and trend arrows.
Like a weather forecast for your blood sugar.
Exactly. They act as an early warning system, allowing a patient to adjust these complex calculations dynamically, catching a rapid drop before it becomes a fatal hypoglycemic event.
It is an incredible technological evolution.
Okay.
Well, we've mapped out a massive territory today. From the absolute destruction of the immune strike in type 1 through the insidious 8-pronged sabotage of the ominous octet in type 2. We looked at the extreme acidotic crash of DKA, the slow-moving structural damage to the vasculature, and finally the pharmacological armor and the mathematical formulas used to fight back.
It is a phenomenal amount of information, but understanding these mechanisms is the only way to truly grasp the complexity of the disease.
To that end, as promised, I want to leave you, our listener, with a rapid-fire mental exercise to reinforce what we've learned. Not to test you, but to let you step into the shoes of someone managing this intricate machinery in the clinic.
Let's do it.
You are in the clinic. A patient presents with a total daily dose, or TDD, of exactly 50 units of insulin. Using those standard clinical constants we just discussed, calculate their initial carb-to-insulin ratio and their high blood glucose correction factor.
Think about the 2 constants we use.
I'll give you a second. Okay, if you took 500 and divided it by 50 to get a 10-to-1 carb ratio, and you took 1650 and divided it by 50 to get a 33-point drop per unit for the correction factor, you are ready for the wards. That is the invisible math happening all around us.
And, that leads to a pretty profound question about the future for everyone listening to ponder.
What's that?
Well, we now know that type 2 diabetes involves at least 8 distinct physiological defects, the ominous octet. Yet, our current therapies primarily target just a few at a time. So how might the next generation of diabetes medications need to evolve to simultaneously fix the brain's insulin resistance and the gut's incretin deficiency in a single stroke?
That is the absolute frontier of metabolic medicine, something to explore on your own. Thank you for joining us on this deep dive. Keep studying, keep asking the hard questions about how the body actually works, and keep connecting the dots. Because as we've explored today, when the biological machinery breaks down, the authors aren't always visible on an X-ray. But the science and the math can still give you a perfectly clear picture. Catch you on the next one.